Let's now talk about pancreatic disorders, and I've divided pancreatic disorders into two modules. In this first module, I'll talk about the benign conditions of pancreas, and in the second module, I'll talk about the malignant conditions of pancreas. Now, in this module, we'll first start with the embryology of the pancreas because there are two congenital conditions which are frequently asked in the exam. The first condition which is asked is pancreas divisum. Now, pancreas divisum is the most common congenital anomaly of the pancreas, and this everyone should know about. I've seen a lot of students making a mistake where they think that annular pancreas is the most common congenital anomaly. That is not the case. The most common congenital anomaly is pancreas divisum. And this is failure of fusion of the dorsal and the ventral pancreatic buds that it gives rise to this problem. So what happens is that in the normal pancreas, you have the main pancreatic duct of Versung, right? This is the main pancreatic duct of Versung which is there, and this is the Versung duct, which is the main pancreatic duct which is going to open along with your biliary opening, along with the CBD opening. This opens at the ampulla of water. This is the normal anatomy which is there. Okay, and this duct which is there, this is joined by the accessory duct of Santorini, right? So in the distal part, the accessory duct of Santorini joins this duct, and this accessory duct of Santorini is going to open at the minor papilla. This is going to open at the minor papilla, and this is going to open at the ampulla of water or the major papilla. Okay. So this is the normal anatomy, and this is when happens when the two ducts fuse. The distal portions fuse and the proximal portions are separate. The accessory duct of Santorini, which is the dorsal duct, that is going to open slightly proximally in the minor papilla, and the main duct opens along with the CBD. In pancreas divisum, what happens that these two ducts don't fuse. So what is going to happen that you have the duct of Versung which is going to open normally. This is our duct of Versung which is opening normally. And you have the duct of Santorini also which opens separately. Okay, so they don't fuse with each other. Now the problem is that Versung was our main duct and majority of the flow is coming into Versung. Right? Majority of this flow is coming into the duct of Versung which is opening at the ampulla of water. But it is not able to handle this much amount of secretions. So the problem with pancreas divisum is that these patients are predisposed to, where these ducts don't fuse, they are predisposed to acute pancreatitis. They are predisposed to acute pancreatitis, and that is the problem in pancreas divisum. Okay. Now, the diagnosis of pancreas divisum can be made by MRCP and ERCP, and the management is only in symptomatic patients. So, only in symptomatic patients who are experiencing attacks of pancreatitis, there we are going to carry out ERCP and sphincterotomy. So there we carry out a sphincterotomy so that the drainage occurs properly, and that is the treatment of pancreas divisum. But only done when the patient is symptomatic. Asymptomatic patients don't require treatment. So the second condition which we have to discuss is annular pancreas, and in this what happens that because of malrotation of the ventral duct, because of malrotation of ventral bud of the pancreas, malrotation of the ventral bud of the pancreas, this encases the second part of duodenum. So the pancreatic tissue is going to encase the second part of duodenum, and that gives rise to an annular pancreas. So you can see here that this pancreatic duct, the ventral pancreatic duct, when it rotates, it is going to completely encircle the duodenum. It encircles the duodenum, and that gives rise to annular pancreas. Now, annular pancreas, in this, the second part of duodenum is encased, and this can be associated with, Down syndrome. It can be associated with duodenal atresia. As well. Now, the clinical features of patients with annular pancreas, we know the second part of duodenum is encased. So this is going to give rise to vomiting. There's going to be obstruction, so there's going to be vomiting. But Normally, it is non-bilious vomiting. Now, this is something which you'll have to remember, because going logically, you would think that if the second part of duodenum is getting encased, it should be bilious vomiting. But usually in this condition, it is non-bilious vomiting with which the patient presents. We know in duodenal atresia, it is bilious vomiting with which the child is going to present. Now, if you do an X-ray in these patients, you can see the double bubble sign. You can see the double bubble sign. Where else did we see the double bubble sign? Correct. We saw the double bubble sign in duodenal atresias, but it can be seen in annular pancreas as well. The investigation of choice for this condition is CECT, and when we do the CECT, you can see here that this is the second part of duodenum and it is getting completely encased by this pancreatic tissue. It is getting encased by this pancreatic tissue. Now, the management of annular pancreas, we just don't cut the pancreatic tissue, because if you cut the pancreatic tissue, that will devascularize the pancreas and also the pancreatic ducts can get cut. So the management here is duodenoduodenostomy. We have to carry out a surgery, and the best surgery is DD, that is duodenoduodenostomy, which was the surgery which we carried out for annular pancreas as well. So we are going to carry out duodenoduodenostomy, which was the surgery for annular pancreas. That is better than duodenojejenostomy. So these were the two congenital problems which I wanted you to know about. Now, the sphincter of Oddi, which guards this ampullary opening, usually comprises of 4 different sphincters. So there are 4 different sphincters which make up the sphincter of Oddi. This question has been asked in many exams, and this is an image directly from Bailey. Now, another problem which can happen with the sphincter of Oddi is that there can be sphincter of Oddi dysfunction. And this has been gaining a lot of importance in recent times, because a lot of patients with post-cholecystectomy syndrome, post-cholecystectomy syndrome means that they keep on complaining of pain even after a cholecystectomy. They have been linked to sphincter of Oddi dysfunction. Now, sphincter of Oddi dysfunction can give rise to biliary symptoms, or it can give rise to pancreatic symptoms, right? So it can give rise to biliary symptoms, or it can give rise to pancreatic symptoms. The biliary symptoms are that the patient is going to present with post-cholecystectomy syndrome, which I just explained to you. Or they can present with biliary colic, right? Or they can present with biliary colic. Whereas patients who have the pancreatic symptoms can present with features of pancreatitis. There can be pancreatitis features, and there can be raised pancreatic enzymes as well. Now, to diagnose sphincter of Oddi dysfunction, the investigation of choice here is ERCP with manometry. So ERCP with manometry is the one which is going to confirm the diagnosis. And if you have a pressure of more than 40 millimeters of mercury, that is what tells us that there can be a sphincter of Oddi dysfunction present in these patients. Now, there is a Milwaukee classification for sphincter of Oddi dysfunction. So first of all, you should know the name Milwaukee classification, because this has been asked in the exam and this is updated in the latest Bailey and Sebastian. You have a different Milwaukee classification for biliary and for pancreatic sphincter of Oddi dysfunction, but the concept is pretty much the same. So I'm talking about the biliary one. So type 1 is when you have biliary pain, biliary or pancreatic pain, plus you have dilatation of the duct, plus you have dilatation of duct, plus you have raised enzymes, right? So all 3 things are there. You have pain also, the ducts are also dilated because of dysfunction, and the enzymes are also raised. That is type 1. Type 2 is when there is pain, plus either there is ductal dilatation or raised enzymes. Either there is ductal dilatation or there are raised enzymes. Right, so this is type 2, and type 3 is only pain, when there is neither ductal dilatation nor is there any raised enzyme levels which are seen in the reports. So these are the 3 types of sphincter of Oddi dysfunctions. The values have not been asked. So type 1 is when you have pain plus raised enzymes plus ductal dilatation. Type 2 is when you have pain plus either ductal dilatation or raised enzymes. And type 3 is only pain. That's all I want you to remember. And type 1 is the one which responds best to treatment. This is the one which responds best to treatment. And what is the treatment which is carried out? So the treatment which is carried out is ERCP and sphincterotomy. We are going to do ERCP. ERCP we know is endoscopic retrograde cholangiopancreaticography. Plus we will carry out a sphincterotomy. We are going to cut the sphincter so that drainage can occur properly. And there is no dysfunction left. Okay, this is best for type 1. Now, Botox can also be tried, but Botox has a high recurrence rate. Because the effect of Botox will go away in a few months. But gastroenterologists usually see the response to Botox. And if the patient is showing good response to Botox, then that candidate will show good response to sphincterotomy as well. Okay, so sometimes this is used as an indirect evidence whether the patient is going to benefit from sphincterotomy or not. So this was regarding sphincter of Oddi dysfunction, where I definitely want you to remember ERCP is the investigation of choice, which is done along with manometry, and secretin stimulation can also be done along with MRCP. And you should know the name Milwaukee classification. Now we move on to the main topic of this module, that is acute pancreatitis. Lots of questions are asked. So acute pancreatitis, as the name suggests, is acute inflammation of the pancreas. And the most common cause of acute pancreatitis is gallstone-induced pancreatitis. The most common cause is gallstone-induced pancreatitis. It is not alcohol. Alcohol is the second most common cause. These two questions have been asked multiple times in the exam. So there should be no confusion at all. Gallstones is the most common and alcohol is the second most common. Now it has been seen that gallstone-induced pancreatitis is more common in females as compared to males. And in patients who have symptomatic stones, the incidence of gallstone-induced pancreatitis is just 3 to 5%. Alcohol is the second most common cause of pancreatitis, acute pancreatitis. The most common cause in children has also been asked in the exam, and the most common cause in children is trauma. And this is usually blunt trauma to the abdomen. And the typical history which you will get is a handlebar injury or blunt injury to the epigastrium, right? So a child is riding his bike or his cycle and suddenly gets hit, and there is a handlebar injury that can predispose to pancreatitis. Also, if you remember the module on abdominal trauma, I have told you that the most important factor in pancreatic trauma is the injury to the main pancreatic duct. Right, that is the most important prognostic factor when we talk about pancreatic trauma, that I've covered in the abdominal trauma module. The iatrogenic cause of pancreatitis is ERCP. This is very important. Endoscopic retrograde cholangiopancreaticography, that can give rise to pancreatitis. This is also seen in usually 2 to 3% patients. This is the most common complication of ERCP. And it has been seen this is more common if it is a therapeutic ERCP. If multiple attempts of cannulation are made, and it is more common in females as compared to males and commonly seen in young patients, right? So these are the points with ERCP-induced pancreatitis which you should know about. Drug-induced pancreatitis, the drugs which can give rise to pancreatitis are antiretroviral drugs, thiazide diuretics, metronidazole, chemotherapeutic agents. Chemo agents can also predispose to pancreatitis. So these are some of the drugs which can give rise to pancreatitis as well. There are other causes like hyperparathyroidism. If you remember the module on parathyroid, I've told you the symptoms: bones, stones, abdominal groans, and psychiatric overtones. And there I told you that the abdominal pain there is mostly due to pancreatitis. Increased triglycerides and increased lipids also predispose the patient to pancreatitis. Pancreas divism. Pancreas divism I've just explained to you, when the ducts don't fuse. Idiopathic pancreatitis, when we can't figure out a cause, and rare cause is also scorpion bite. Now, it is very important to understand the pathophysiology of acute pancreatitis. Why does acute pancreatitis occur? So the sentinel, the basic event which occurs is that we know there are inactive enzymes inside the pancreatic acini. Now, these pancreatic enzymes, when they come into the duodenum, that's when they get activated because of the alkaline medium of the duodenum. That's what you've read in physiology. Now, supposing these enzymes become activated inside the pancreas. So if they become activated inside the pancreas, they will start eating up the pancreas and they will cause inflammation. And that is what triggers acute pancreatitis. So what happens in acute pancreatitis is, whatever the stimulus might be, whether it is alcohol, it is gallstone blocking it, that leads to rise in calcium. So there's sustained rise in calcium, which is why hyperparathyroidism, because there's rise in calcium, can also predispose to pancreatitis. And there is co-localization of zymogen and lysosome. This is very important. That is why the most acceptable theory for acute pancreatitis is the co-localization theory, where zymogen granules and lysosome will be co-localizing and they fuse. And when they fuse, this trypsinogen is going to release cathepsin B. And this active trypsin is the one which is going to trigger acinar death. And there is an inflammatory cascade which is there, right? So co-localization of zymogen and lysosome, increased trypsin, and that trypsin is going to trigger death and inflammation. And when there is inflammation, there are mediators which are released. So it is mediated by IL-1, IL-6, TNF-alpha, IL-10. These are some of the markers which are raised in acute pancreatitis. And more severe the attack, more will be the inflammatory mediators which are going to be released in acute pancreatitis. So this is the pathophysiology. The theory behind it is co-localization theory. In biliary pancreatitis, there is also a role of bile reflux. They say because of increased pressure, there is bile reflux, which can trigger this inflammation. So this was the pathophysiology of acute pancreatitis, which I wanted you to know. The clinical features of acute pancreatitis. So usually the clinical features are very subtle. If it's a mild attack, the clinical features are very subtle. One constant feature which usually the patient is going to come with is pain epigastrium, which radiates to the back. So there is pain epigastrium, which is going to radiate, which radiates to the back, and it is relieved on bending forwards. Okay, so pain epigastrium radiating to the back, which is relieved on bending forwards, is a classical feature of acute pancreatitis. Now, in addition to this, it has been seen that the symptoms are out of proportion. Symptoms are out of proportion to clinical signs. Symptoms are out of proportion to the clinical signs. That means the patient will be wincing in pain. Patient will be saying he has a lot of pain. But when you palpate the abdomen, you will not see so many signs there. If it is severe pancreatitis, sometimes the patient can have features of peritonitis, right? So we have discussed the features of peritonitis. What are the features of peritonitis? There is guarding, rigidity, rebound tenderness, right? So if it is severe pancreatitis, some patients can present with similar features. And I still remember a case when I was a postgraduate. This was when I was a second year postgraduate. And we had this male who had come with a history of upper abdominal pain. And when we did the X-ray, we could not see any gas under the diaphragm, right? There was no gas under the diaphragm, but this patient had classical features of peritonitis. So at that time, my senior resident spoke to our consultant and they said that this patient needs to be explored because there might be a perforation, but we are not seeing any gas. And we were surprised when we opened the abdomen, we saw these calcific spots, like saponification happens. So when pancreatitis happens, there is saponification. So there were these whitish spots studded all over the abdomen and there was no perforation, it was actually a case of acute pancreatitis. So in severe cases, there can be features of peritonitis as well. Now, in patients with acute hemorrhagic pancreatitis, there can be certain clinical signs which can be there. So what are the clinical signs which are present? So you can have Cullen's sign and Gray Turner sign. So Cullen's sign is discoloration around the umbilicus. You can see here there is a discoloration around umbilicus. Right, discoloration around the umbilicus is Cullen's sign. Remember C for central, so the discoloration will be around the umbilicus. Or you can have Gray Turner sign. Gray Turner sign is when there is discoloration in the flanks. And this discoloration is basically occurring because of retroperitoneal bleeding. Because of retroperitoneal bleeding, this discoloration tracks along the abdominal wall and it can come around the umbilicus or in the flanks. You can also have Fox sign. Fox sign is discoloration in the inguinal region. If you have discoloration in the inguinal region, that is known as Fox sign. So these are the symptoms and the signs which you can get in a patient with pancreatitis. Now, these patients with pancreatitis usually come to the emergency with pain. And how do we make the diagnosis? So there is an international consensus which says that the diagnosis of acute pancreatitis can be made when 2 out of the following 3 features are there. And these have been taken directly from the latest edition of Sebastian. So there should be abdominal pain consistent with acute pancreatitis. That means pain in the epigastrium which radiates to the back. There should be a 3-fold or higher elevation of serum amylase or lipase above upper laboratory level. And characteristic findings of pancreatitis on imaging. So out of these 3 things, pain, raised enzymes and imaging, if 2 things are present, then we can make the diagnosis of acute pancreatitis. Now, when the patient comes, what are the investigations which are ordered out in these patients? So when these patients come to us, the first investigation which we send out in such patients is serum amylase and serum lipase. Of course, you will take blood for both of them together. Now, amylase rises quickly and has a shorter half-life. So it settles down as well. Okay. Whereas serum lipase rises gradually. This rises gradually and it has a longer half-life, so it persists for a longer duration. So why is this important? Because supposing the patient only comes after 3 or 4 days, then in those patients the amylase values can be low because the half-life is shorter, but lipase will be high. So that is why we send out both amylase and lipase. And you should know that lipase is more specific for acute pancreatitis than serum amylase. It is more specific for acute pancreatitis than amylase. Amylase can be raised in other conditions as well. And what are the other conditions where amylase can be raised? It can be raised in pancreatitis where it is 3 to 4 times the normal value. But it can be raised in other acute abdominal conditions like mesenteric ischemia, perforated ulcers, volvulus torsion, and salpingitis. These are the other cases where amylase can also be raised, which is why it is not a very specific modality for acute pancreatitis. So I've told you about amylase and lipase. I would also like you to know that if the liver enzymes are raised in a patient with acute pancreatitis, then it is suggestive of biliary pancreatitis. So we should also look at the liver function tests in these patients with acute pancreatitis. Talking about blood tests, one more thing which I want you to know, these patients can develop hypocalcemia. And why do they develop hypocalcemia? Because I told you there is saponification. When these enzymes are released, there is saponification which happens in the abdomen. And because of this saponification, calcium can get chelated and there can be hypocalcemia. No, hypercalcemia can cause acute pancreatitis, but the patient will usually come with hypocalcemia. That is why we should see this and we should correct it as well. Now, one more thing which I want you to know, I told you amylase and lipase. Amylase is sensitive, lipase is more specific. But both amylase and lipase are not predictive of severity, of attack, right? So there is no link between the amylase or the lipase value and how severe the attack was. So this you should know about. That is why when I tell you about the severity scores, you will notice that none of the severity scores have amylase or lipase in them. The radiological signs which we can see in patients with acute pancreatitis, there are certain non-specific signs. One of them is a colon cutoff sign, which you can see on imaging. On an X-ray, you can see that there can be a cutoff in the large bowel, and this basically occurs because of ileus. Because there is inflammation in the abdomen, because of that the bowel does not contract, there is ileus, and that can give rise to a colon cutoff sign. Similarly, you can have a sentinel loop sign. This also occurs because of ileus, and this is a focal dilated jejunal loop. Which can be seen, that is known as sentinel loop sign. And another question which was asked in the All India exam, you can get gasless abdomen. In patients with acute pancreatitis. Where else can we see a gasless abdomen? We can also see gasless abdomen in acute gastroenteritis and diarrhea as well. But in acute pancreatitis also we can see it, and that was asked in the exam. Now, the best imaging modality for acute pancreatitis is CECT, contrast enhanced CT scan, is the investigation of choice for acute pancreatitis, right? But it has been said that CECT should be done after 72 hours of onset of symptoms. After 72 hours of onset of symptoms, we should carry out CECT, because it has been seen that if CECT is done within 72 hours, it can undervalue or underestimate the attack, underestimate the extent of acute pancreatitis. So that is why we should do it after 72 hours of onset of symptoms. That is when CECT abdomen should be carried out. One more thing which you should know, that the portal venous phase in CECT, and these are direct lines out of Bailey. The portal venous phase in CECT, that means which occurs 65 to 70 seconds after injection of the contrast. This is the most sensitive phase. Which tells us about pancreatic necrosis. So whether the pancreatic tissue is viable or non-viable, this we will get to know in this portal venous phase. Now in this CT, you can see that the pancreas is bulky and edematous, and there is some peripancreatic collection which is suggestive of acute pancreatitis. So CECT is the investigation of choice, and I want you to know about this portal venous phase being the most sensitive for pancreatic necrosis. Now, once we've made the diagnosis, the other thing in acute pancreatitis is to find out the severity of the attack, because the severity is also going to determine the mortality. Now, before I tell you about the severity, I want you to know mortality. There are two spikes of mortality in acute pancreatitis. One is the early spike, which is going to occur within a few days. And this is mainly because of the inflammatory cascade which occurs. This is because of the inflammatory mediators which occur, and these inflammatory mediators, which I told you in the pathophysiology, can give rise to multiple organ dysfunction syndrome. I've already covered the definition of MODS in the shock module, multiple organ dysfunction syndrome. That is what can give rise to early death. The late death which occurs in acute pancreatitis after a few days is mainly because of sepsis. So these are the two causes of mortality in acute pancreatitis, and that is why it is very important for us to know the severity of the attack. So the first criteria is the Glasgow criteria. The Glasgow criteria, you don't need to remember the details, although the mnemonic is very simple. It is pancreas, What you need to remember in Glasgow criteria is that a score of 3 or more than 3 is associated with severe pancreatitis, and there is increased mortality if there is severe pancreatitis. So score of 3 or more than 3 is severe pancreatitis with the Glasgow score. The Ranson score is very, very important. It has been asked multiple times in the exam, and the Ranson's criteria is different for alcohol-induced pancreatitis, and you have a different criteria for biliary pancreatitis. Right? And another thing which you should know in Ranson's criteria is that there are certain values which are measured on admission and certain which are after 48 hours of admission. Okay, and Ranson scoring you need to remember for the exam, because this was at one time a pet favorite of the PGI exam. So this can even be asked in the INI CET exam, and you should remember the values of the Ranson scoring. So this includes WBC more than 16,000, age more than 55, blood glucose more than 200, AST more than 250, and LDH more than 350. After 48 hours, a decrease in hematocrit by 10%, blood urea nitrogen increased by 5, calcium hypocalcemia, I told you, less than 8, this can occur, PO2 less than 60, base deficit more than 4. Right? Base deficit means that there is acidosis, and fluid requirement more than 6 liters. And again, a Ranson score of 3 or more than 3 is severe pancreatitis. A Ranson score like Glasgow score, a score of 3 or more than 3 is severe pancreatitis. Now, because Ranson scoring involved a lot of testing and lot of investigations, that is why a simpler score known as the BISAP score was launched. The BISAP score includes blood urea nitrogen, impaired mental status, SIRS, age more than 60, and pleural effusion. And again, a BISAP score of 3 or more than 3 is also suggestive of severe pancreatitis. So you should remember the names of all these scoring systems. Ranson's you should remember in detail. Now, other scoring systems which are there, other scoring systems also which are used. So C-reactive protein value more than 150 international units per liter is suggestive of severe pancreatitis. The Apache score, Apache is very important. Apache stands for Acute Physiology and Chronic Health Evaluation score. This is Acute Physiology and Chronic Health Evaluation score. Chronic Health Evaluation score, and an Apache score of 8 or more than 8 is suggestive of severe pancreatitis. And you also have the Apache O score, right? The Apache O score, where O is for obesity, and this is also a specific score for pancreatitis which you should know about. Other scorings are the HAPS score. HAPS is the harmless acute pancreatitis score. You have the harmless acute pancreatitis score. And you also have the modified Marshall score. So the modified Marshall score tells us about organ dysfunction. And this has been mentioned in Bailey. The modified Marshall score tells us about organ dysfunction. This is the modified Marshall score. And it tells us about organ dysfunction, and you should know a score of 2 or more than 2 is suggestive of organ dysfunction. So you should know about this as well. Now, amongst all these scores, the best scoring system is the Balthazar score or the CT severity index. You have the CT severity index. This is the best scoring system for acute pancreatitis. And this has been asked in multiple exams, right from FMG till super speciality. It has been asked that the CT severity index is the best scoring system for acute pancreatitis. Now, the CT severity index takes into account 2 things. It takes into account the Balthazar's grade, which is from 0 to 4, where normal pancreas is 0. You have focal or diffuse enlargement of pancreas is 1. Pancreatic gland abnormalities and peripancreatic inflammation is 2. Fluid collection, if there's a single fluid collection, it is 3. And 2 or more fluid collections or gas bubbles is a score of 4. In addition to this, you have to add the pancreatic necrosis score, and 30 up till 30% is a score of 2. 30 to 50 is score of 4, and more than 50% is a score of 6. right? And when you add them up, you get a total score of 10. The maximum score is 10, and higher the score, more severe is the pancreatitis. You should know a score of 6 or more than 6 denotes severe pancreatitis. A score of 6 or more than 6 denotes severe pancreatitis. So any patient who has more than 50% pancreatic necrosis also automatically qualifies as severe pancreatitis because the score will be 6. Right? So 6 or more than 6 is severe pancreatitis. And these are the various scoring systems which are there for acute pancreatitis. So what have we done till now? We've discussed the causes, we've discussed the clinical features, we've discussed how to work up a patient, how to confirm the diagnosis, and how to judge the severity. Now comes the time to manage these patients with acute pancreatitis. And the management of acute pancreatitis, because the patient is in a state of ileus and there is pain, we make the patient nil per oral. So we will give bowel rest. We give bowel rest. We put in a Ryle's tube as well because there's ileus, there can be vomiting. We put in a Ryle's tube. We will give IV fluids, and in Sebastian it is written that ringer lactate RL is the best IV fluid which can be initially given in patients with acute pancreatitis. Analgesics are given adequately to control the pain, and earlier it was thought that morphine should be avoided. Why were they avoiding morphine? Because morphine causes spasm of the sphincter foci, and they thought that if it causes spasm, it can cause more pain and more backflow. But it is now been seen that we can even use opioid analgesics in these patients safely, so we should control the pain properly in these patients. There is no role of empirical antibiotics. No role of empirical antibiotics in patients with acute pancreatitis. It should only be given if there is severe pancreatitis, or if there is infected necrosis, or there is necrosis more than 50%. These are the patients who are going to benefit from antibiotics, and the antibiotic of choice is meropenem. Imipenem or meropenem is the antibiotic of choice. This has also been asked in one of the exams. But in other patients with mild to moderate pancreatitis, there is no role of antibiotics. Now, nutrition is also a major thing in these patients, and nutrition, if you remember the module on nutrition, I told you that early phase of acute severe pancreatitis, in this early phase of acute severe pancreatitis, we can use parenteral nutrition. That means we can use TPN, but we should start enteral nutrition early. And by starting enteral nutrition early, what are we doing? We are reducing the infectious complications. We are reducing infections. And how are we reducing infections? If you remember your module on nutrition, remember what did I tell you? That when we give food through the gut, that prevents translocation of gut bacteria. Right? If bacteria inside the gut are getting food, then they will not travel outside the gut. And if they don't travel outside the gut, they will not cause infections. So that is why early initiation of enteral nutrition reduces the infectious complication. Which can occur with acute pancreatitis. So we should know about this. And it has been recommended that a nasovaginal feeding is better, because there can be ileus, so it is better to do nasovaginal feeding than nasogastric feeding. So these were the points in the management which I wanted you to know. 2 more points in management. One, what is the role of ERCP and what is the role of cholecystectomy in gallstone-induced pancreatitis? So the role of ERCP, there is no routine use of ERCP. No routine role of ERCP is there. It is only in biliary pancreatitis, only when it is gallstone-induced pancreatitis and there is pain which is lasting for more than 48 hours, which is not settling down, when there are features of obstruction and jaundice, which are there, or you have a patient where there are documented stones, in the CBD. These are the patients where we need to carry out an ERCP in biliary pancreatitis. Otherwise, routine patients don't require ERCP. Also, any patient who's admitted with gallstone-induced pancreatitis, cholecystectomy should be done before discharge. This is very important. Cholecystectomy should be done before discharge. So I remember I had a senior resident of mine, and this senior resident was a bit on the heavier side, and he had gallstones. And on one of our emergency days, he developed epigastric pain, and when we investigated, he was found out to have gallstone pancreatitis. Although it was a mild attack, he settled down. So before discharge, we remember he was admitted for 5 days. On the 6th day before discharge, he underwent a laparoscopic cholecystectomy. So that is the recommendation. Cholecystectomy should be done in all patients with gallstone pancreatitis before discharge. This is how we manage patients with pancreatitis. Now, pancreatitis can be associated with complications, right? And there are some Atlanta classification definitions which you should know about, and then we'll talk about the complications as well. So according to the Atlanta classification definitions, you can have mild, moderate and severe attack of pancreatitis. There can be mild, moderate or severe attack of pancreatitis, and we can take into account local complications, and we can take into account organ dysfunction. So in mild pancreatitis, neither are there local complications nor are there any organ dysfunction, or is there any organ dysfunction seen in these patients. In moderate, local complications are present and organ dysfunction can be transient. Transient means till 48 hours there can be some organ dysfunction. Whereas in severe pancreatitis, there are both local complications and organ dysfunction or systemic complications are also seen. So this is how we can judge mild, moderate or severe attack. Now, what are the complications which can occur in pancreatitis? So the complications of pancreatitis, like I told you, they can be local complications or you can have systemic complications. First, let's talk about the systemic complications. The systemic complications, any organ can be affected, because what is happening? There is SIRS, Systemic Inflammatory Response Syndrome. All these inflammatory mediators which are getting released can cause organ dysfunction. And this I've covered in the module on shock. I've spoken about SIRS, I've spoken about sepsis, I've spoken about septic shock, I've spoken about MODS, multiple organ dysfunction syndrome. There can be ARDS, acute respiratory distress syndrome. There can be congestive heart failure, which can be seen. So these are the systemic complications which can be seen in patients with acute pancreatitis. The local complications of acute pancreatitis, you can have pancreatic ascites. There can be pancreatic ascites which can be there. There can be peripancreatic fluid collection. There can be peripancreatic fluid collection. These patients can have pancreatic necrosis. There can be pancreatic necrosis which can develop in these patients. Pseudocysts can form. All these we will talk about in detail. Then there can be vascular complications which these patients can have, which also I will talk about, vascular complications. And these patients can also develop left-sided pleural effusion. Left-sided pleural effusion. So these are the complications, and you should know these complications because this in itself is a short note which is asked in the college exams. So let's talk about these complications one by one. There can be pancreatic ascites. And why does pancreatic ascites develop? This occurs because of disruption of the pancreatic duct. So when there's disruption of the pancreatic duct, there is a lot of collection, a lot of fluid which is collected in the abdomen. So there's significant abdominal distension with intra-abdominal fluid. Now, because this fluid is coming from the pancreas, it will of course be rich in amylase and lipase. So the fluid itself is rich in amylase and lipase, and it is protein rich as well, right? It is protein rich also. So the management of pancreatic ascites is we have to carry out paracentesis. That means we have to drain this fluid, plus we have to place a stent across the pancreatic disruption. Also, it has been seen that octreotide and somatostatin analogs also help in reducing pancreatic ascites. Stenting of the duct is very important, and that will be done via ERCP. Okay, so this is pancreatic ascites. If there is just minor peripancreatic fluid, then conservative management. If it is just small amount of fluid which is there and the patient is not symptomatic, then we just do conservative management in those patients. One of the most serious complications of acute pancreatitis is pancreatic necrosis. And pancreatic necrosis, I told you, the best way to find out about pancreatic necrosis is on CECT, and we get to know this on the portal venous phase is when we will get to know whether the pancreatic tissue is necrosed or not. Now, this pancreatic necrosis which can be there, this can either be sterile necrosis or it can be infected necrosis. It can either be sterile necrosis or infected necrosis. You can see in this CT, you can see that all this tissue, the blackish tissue which you can see is all dead pancreatic tissue. This is all dead pancreatic tissue. Now, if it is infected necrosis, how do we get to know about it? So these patients will have a raised TLC. They will have raised TLC. They can be running fever. They can have other features of sepsis. And on CT, you will see gas. You can see gas bubbles. Although not seen in a lot of patients, but if gas bubbles are seen, then it is almost diagnostic that it is an infected pancreatic necrosis. So these are the subtle points which will tell us whether the patient has a sterile necrosis or the patient has infected pancreatic necrosis. Now, how do we manage pancreatic necrosis? If it is sterile necrosis, no active intervention, right? No intervention routinely. If it is sterile necrosis, only indications for intervention are persistent pain, failure to improve clinically, or if there is biliary or enteric obstruction. So these are pretty much on the same lines as we spoke about for ERCP, right? We were doing ERCP if there was persistent pain, if there was biliary obstruction, or if there was failure to improve clinically. Same are the indications to intervene in sterile necrosis. What are the interventions? I will just tell you once I talk about infected necrosis, then I will talk about the interventions as well. Infected necrosis, when I told you how do we diagnose infected necrosis, and infected necrosis we have to carry out intervention. We have to carry out intervention in these patients, that is for sure. Now, we usually follow the step-up approach, right? And this is what is given in Sebastian and in Bailey. The step-up approach, there were multiple trials which were done. And they said that you always start from minimally invasive techniques and then move on to more complex techniques. Because it was seen that if early interventions or early open interventions were being done, there was very high mortality in patients with pancreatic necrosis, which is why the step-up approach says that first you do percutaneous drainage, right? And this we know can be done using a pigtail catheter. So under image guidance, we put in a pigtail catheter and drain the necrosis. This is followed by minimally invasive retroperitoneal debridement. And if this also does not work out, then we can do open debridement. Then we can do open necrosectomy. But like I told you, open necrosectomy has a very high mortality rate. Another way to drain this necrotic pancreatic collection is the Beggar's method, and this is given in Bailey as well. So this is the Beggar's method where we put in two drains. In the lesser sac. These are the drains which are put in the lesser sac, and continuous irrigation, right? We do continuous irrigation. So we put saline from one side, it comes out from the other side. Then we put from this side, it comes out from this side. So this is another method to drain pancreatic necrosis. Now, there are certain Atlanta classification guidelines or definitions also which you should know for acute pancreatitis. And you can have acute peripancreatic collection, acute necrotic collection, pseudocyst, and walled-off necrosis. These are the four definitions which are given, and I'll just tell you very simple ways to remember these four definitions. Now, acute peripancreatic collection, wherever the word acute is there, acute peripancreatic or acute necrotic, wherever acute word is there, it is less than 4 weeks. And when it is less than 4 weeks, the wall is not fully defined. No fully defined wall. Okay. Now, peripancreatic collection will be homogeneous because there is no infection. It is usually adjacent to the pancreas and confined in the normal facial planes. And these patients with just peripancreatic collections, I told you it is conservative management. We just do conservative management. So in acute necrotic collection, the word acute is there, so it is less than 4 weeks. But because it is necrotic, I just told you there will be heterogeneous collection. The wall is not fully defined, and this can either be intra or extra pancreatic. The management of acute necrotic collection, I've already told you, is a step-up approach which we just discussed, where we first do a pigtail insertion, then we can do minimally invasive technique, and then finally open method. And I've told you that this also carries a very high mortality. Also, this necrotic collection, if it is infected, it is usually a gram negative. It is usually a gram negative infection, and E. coli and Klebsiella are the major culprits. Now, the other two definitions are pseudocyst and walled-off necrosis. Pseudocyst I'll cover in detail. Let me just tell you that the word acute is not there, so this is more than 4 weeks, and the wall will be fully defined. And because there's no necrotic word added, it is a homogeneous collection. Walled-off necrosis is more than 4 weeks. Wall is fully defined, but it is a heterogeneous collection which is there. And walled-off necrosis also, we have to carry out a pigtail catheter insertion and we have to drain out the collection. So these were certain definitions which I wanted you to know. Now, we were talking about the complications of pancreatitis, and I told you there can be vascular complications as well. Now, these vascular complications, the most common vessel which is involved, is the splenic artery. Is the splenic artery which can be involved, and this gives rise to a splenic artery pseudoaneurysm. There can be splenic artery pseudoaneurysm, and if you remember your module on arterial disorders, I've already covered about splenic artery aneurysms. Also in the spleen module, I've covered about splenic artery aneurysms in great detail. And I've told you that embolization can be done, or in certain cases when it is proximal, it's a large one, or this is also common in pregnant patients, there even ligation can be carried out. Usually it is embolization. You should know that this is the most common vessel involved in acute pancreatitis. The gastroduodenal artery can also be involved. Gastroduodenal artery can be involved as well in acute pancreatitis. Also, there can be splenic vein thrombosis. Splenic vein thrombosis can also be there. Splenic vein thrombosis, I have discussed in the module on upper GI hemorrhage, that this splenic vein thrombosis can give rise to left-sided portal hypertension. This can give rise to left-sided portal hypertension. And another name for this portal hypertension, which is given in Bailey, is sinistral portal hypertension. And the management for these patients is splenectomy. Okay. The mesenteric artery involvement is extremely uncommon. It is usually not seen in acute pancreatitis, but all the other surrounding vessels like splenic artery, gastroduodenal artery, splenic vein, and portal vein, these can undergo complications during acute pancreatitis. So these were the vascular complications which I wanted you to know. Now, the only complication which is left is pseudocyst, and pseudocyst is also very important for the exam. It is asked as a separate question as well. So pseudocyst, as the name suggests, this is a false cyst. This is a false cyst which is lined by granulation tissue. So this is lined by granulation tissue and it is a false cyst. And the most common site for a pseudocyst is the lesser sac. The most common site for pseudocyst is the lesser sac. Lesser sac, you know, is the space behind the stomach and above the pancreas. That is your lesser sac. That is the most common site. But it can occur anywhere in the abdomen. And a lot of students think that it is more common in acute pancreatitis, but in reality, pseudocysts are more common in chronic pancreatitis as compared to acute pancreatitis. It is more common with chronic pancreatitis as compared to acute pancreatitis, so that also you should know about. Now, pseudocyst, how does the patient present? Like I told you, the collection will be in the lesser sac. And lesser sac is behind the stomach and above the pancreas. So when there is a collection there, what will it do? It is going to push the stomach up. It will push the stomach up. And when the stomach gets pushed up, there will be an epigastric swelling and the patient will keep on having nausea and vomiting. So the clinical features would be epigastric swelling. The patient can have epigastric swelling. There can be nausea and vomiting, which can be seen in these patients. Okay. The investigation of choice in these patients is a contrast enhanced CT scan, which is going to tell us about the pseudocyst. Now, you have a D-Agadio classification as well. And on this CT, we also get some very important information regarding the management of these pseudocysts. Now, the D-Agadio classification for pseudocysts, there are 3 types of pseudocysts which are there, type 1, type 2, and type 3. And type 1 pseudocysts are usually seen with acute pancreatitis, and usually there is no cystoductal communication. Means there is no communication between the pseudocyst and the main pancreatic duct. So it is usually seen in acute pancreatitis and the anatomy of the duct is normal. There's usually no fistula or communication. Type 2 is ones which are seen in acute or chronic pancreatitis and there might be abnormal anatomy. Type 3 is when there's chronic pancreatitis, there might be abnormal anatomy of the duct with strictures and these are always communicating, right? So they always communicate with the main pancreatic duct. Now, what is the significance of this communication with the main pancreatic duct? This I will discuss when I talk about the management. This is a very important point which we have to keep in mind. Now, this is what a pseudocyst looks like on CT. This you can see is the lesser sac. This is the area of the lesser sac where the collection is. And you can see that the stomach is getting pushed up, right? So this is the most common site for a pseudocyst, that is the lesser sac. Now, how do we manage patients with pseudocysts? So management of patients with pseudocysts, majority of the pseudocysts resolve spontaneously. Majority are going to resolve spontaneously. Majority resolve spontaneously. 70% resolve spontaneously. Okay. Now, only those, what are the indications when we have to intervene? So the indications for intervention are when the cyst is more than 6 centimeters in size, when it is more than 6 weeks old, when it is more than 6 weeks old, or when the wall thickness is more than 6 millimeters. When the wall thickness is more than 6 millimeters. These are the indications for intervention. Otherwise, majority will resolve on their own. Now, what are the various interventions which can be done? So the interventions which can be done, we can either do external drainage or we can do internal drainage. Okay, we can either carry out external drainage or we can do internal drainage. Now, external drainage is only done when it is an infected pseudocyst. When it is an infected pseudocyst, that is when external drainage is done, and in minor cases when there is acute hemorrhage inside the cyst. When there is acute hemorrhage inside the cyst. Okay. Otherwise, mainly it is done when it is an infected pseudocyst. Now, one problem with external drainage is that if communication with main pancreatic duct is there, if communication with main pancreatic duct is present, then it can give rise to a fistula. It can give rise to a pancreatic fistula. Okay. Which is why before we do external drainage, we should always rule out communication with the main pancreatic duct. Okay. And that is why which fistulae we should not do external drainage? Type 3. Because there will always be communication. But what if a type 3 fistula is infected? Then what do we do? So there is a way out that if there is communication, if communication is present, then we have to do stenting. Then we have to do ERCP and stenting of the main pancreatic duct, and then we can carry out external drainage as well. So if communication is present, then ERCP and stenting of the main pancreatic duct should be done. So this was the significance of knowing the communication. Now, if it is internal drainage methods are endoscopic, laparoscopic, and open methods. And what are the methods? So what are the two things which can be done. So we can either do cystogastrostomy, that means we anastomose the cyst with the stomach, or we can do a cystojejunostomy, we can anastomose it with the jejunum. These are the two things which can be done, and there are three ways how it can be done: endoscopically, laparoscopically, and open. Of course, these days what is preferred is endoscopic method. So how is the endoscopic method done? We are going to put in an endoscope. I put in the endoscope through the mouth and I go into the stomach, right? And I go into the stomach. So this is the stomach. I'm going to put the endoscope through the mouth, go into the stomach. Now this posterior wall of the stomach is just above the lesser sac. This was the lesser sac, which is abutting the posterior wall of the stomach. Now with the endoscope, I'm going to open up the posterior wall and I'm going to enter into the pseudocyst. And endoscopically, I'm going to staple the pseudocyst wall with the stomach wall. So this is the minimally invasive technique, and you can also call it a Notes procedure. Remember Notes? Notes we've covered at multiple places. That is natural orifice transluminal endoscopic surgery. So this is how majority of the pseudocysts are now being treated. If this is not possible, then we either do it laparoscopically or we do it via the open method. If the pseudocyst is adherent with the stomach, we do a cystogastrostomy. And if it is close to the jejunum, we will do a cystojejunostomy. Now, a very common doubt which students have is that, sir, if you anastomose the stomach with the pseudocyst, whatever the patient eats will then go in the pseudocyst. But that usually does not happen, because this is usually with the posterior wall, and the peristalsis of the stomach takes the food to the pylorus. It does not go into the posterior wall cavity. Okay, so if somebody asks you, you have to say that the stomach contraction is in such a way and the flow of food is such a way that it goes to the pylorus along the lesser curvature, and it usually does not go into the posterior wall and into this cystogastrostomy cavity which we have created. So these are the interventions. Now there are two things. One is what are the complications of pseudocyst surgery? Complications of pseudocyst surgery, and the most common complication of pseudocyst surgery is hemorrhage. Hemorrhage is the most common complication of pseudocyst surgery. There can be infection as well. But there are certain complications of pseudocysts as well. These were the complications of pseudocyst surgery. What are the complications of pseudocysts? So the complications of pseudocysts, the most common complication is infection. Most common complication of pseudocyst is infection. Hemorrhage can occur inside the cyst. The cyst can rupture. It can mimic a cystic neoplasm. So in the next module, I will tell you about mucinous neoplasms of the pancreas, right? This pseudocyst can mimic a mucinous neoplasm, because even in a mucinous neoplasm, there will be a history of pancreatitis which will be there. So how do we differentiate? The value of CEA, carcinoembryonic antigen, would be less than 400 in pseudocysts. The value of CEA in the fluid, where in the fluid of this cyst, will be less than 400 in patients with pseudocysts. Finally, there can be a pancreatico-pleural fistula which can also form, and that can give rise to pleural effusion. And in these patients also we have to stent the main pancreatic duct, right? Because the fistula is usually forming because there is communication with the main pancreatic duct, and that main pancreatic duct has to be stented. So this was the management of acute pancreatitis, where we've discussed right from the causes till the complications. This is a very, very important topic from the point of view of your exam. Now we move on to chronic pancreatitis. Chronic pancreatitis is when, because of repeated attacks, there is fibrosis, right? There is fibrosis and chronic inflammation. Fibrosis and chronic inflammation. And this gives rise to irreversible damage. This gives rise to irreversible damage to pancreatic parenchyma. So irreversible damage to pancreatic parenchyma can be there. Now this can either occur after one episode or in some patients usually multiple episodes of acute pancreatitis give rise to this condition. There is a TIGAR-O classification with which you can remember the causes of chronic pancreatitis. So the TIGAR-O classification, T is for toxins. These toxins can be alcohol, cigarette smoking, and we should know that alcohol is the most common cause of chronic pancreatitis. Alcohol was the second most common cause of acute pancreatitis, but it is the most common cause of chronic pancreatitis. There can be cigarette smoking, hypercalcemia or hyperparathyroidism, hypertriglyceridemia, and chronic renal failure. It can be idiopathic, early onset or late onset. The cutoff is 35 years. There can be genetic factors, and this is very important. In the next slide, I'll talk about the genes which are associated with chronic pancreatitis. And in multiple central institute exams, these genes have been asked. Okay, these are the PRSS, CFTR, and the SPINK1 genes. And PRSS1 gene, very important, is on chromosome 1. This is your protease serine 1 gene, and this is linked with hereditary chronic pancreatitis. So PRSS1, hereditary chronic pancreatitis, and this increases the risk of cancer. This increases the risk of cancer. Okay. SPINK1. SPINK1 is a peptide secreted by acinar cells that regulates premature activation of trypsinogen, and this is associated with chronic or tropical calcific pancreatitis, which is seen in India and is due to cassava ingestion. So this has also been asked in all possible Indian exams. SPINK1, tropical calcific pancreatitis, and linked with cassava ingestion. CFTR gene, CFTR gene, if there is a homozygous mutation, then this gives rise to cystic fibrosis. But if there is a heterozygous mutation of CFTR gene, then it can predispose to chronic pancreatitis. And all chronic pancreatitis patients have an increased risk of pancreatic cancer. Autoimmune pancreatitis is of two types, type 1 and type 2. Type 1 is more common, and type 1 is more common than type 2, and this is IgG4 related. Remember, at various places we spoke about IgG4 wherever there was fibrosis happening. So there is retroperitoneal fibrosis, Peyronie's disease, Dupuytren's contracture. So all those places it was IgG4. And to diagnose type 1 autoimmune, you have the Hissort criteria. You have the Hissort criteria to diagnose type 1 autoimmune pancreatitis. H is for histology. H is for histology, which is there. H is for histology, in which you can see lymphocytic infiltration and there will be fibrosis. I is for imaging. S is for serology, where IgG4 will be raised. There will be increased IgG4. O is other organs. So other organs, I remember I just told you Riedel's thyroiditis, Peyronie's disease, retroperitoneal fibrosis, Dupuytren's contracture. So all these also, if they are involved, it strengthens the diagnosis of IgG4-induced pancreatitis. And RT is response to steroids or response to therapy. RT is response to therapy. So this is the Hissort criteria which is used to diagnose patients with autoimmune pancreatitis. Type 2 or IgG4 negative pancreatitis. TIGAR-O is obstructive, that means pancreas divisum, and if there's scarring of the scarring of the duct, right? So these are the causes of chronic pancreatitis which you should know about. I've already told you about the genes for chronic pancreatitis as well. So the clinical features of chronic pancreatitis, these only we see when there's more than 90% destruction of pancreatic tissue. When there's more than 90% destruction of pancreatic parenchyma, that is when we will see the exocrine and the endocrine features of chronic pancreatitis. So there can be three types of problems. You can either have exocrine insufficiency, and this I told you, you need more than 90% destruction of pancreatic parenchyma because before exocrine insufficiency manifests, and endocrine insufficiency can also be there. Of course, exocrine insufficiency is more common than endocrine insufficiency. Now, exocrine insufficiency means there will be decreased pancreatic enzymes, and when there are decreased pancreatic enzymes in these patients, then these patients are going to come with malabsorption, right? These patients are going to come with malabsorption. That is how these patients are going to come to us. Endocrine insufficiency, when there's decreased insulin, these patients are going to come with diabetes mellitus. They will come with diabetes mellitus. And the third main problem in these patients with chronic pancreatitis is pain. Now, pain can be there because of multiple reasons. Pain can be there because of ineffective drainage. It can be there because of ineffective drainage, which can occur, right? This can be there because of fibrosis within the tissue. And this can also occur because of stones in the main pancreatic duct, and these stones are usually calcium carbonate stones. These are calcium carbonate stones. This has also been asked in the exam. So these stones which form in the main pancreatic duct are usually calcium carbonate stones. And there is one more thing, one very interesting fact which I want to share with you, and this is given in Sebastian as well. There is something known as a burned out pancreas. There is a burned out pancreas. So people think that as the pancreatic destruction increases, the pain would also increase, right? Pain also increases. But this phenomena of burned out pancreas is that as the destruction increases, the pain usually in patients with chronic pancreatitis would usually reduce. So pain is more in the initial phases, but as more and more acini die off, the pain would reduce. This is known as the concept of burned out pancreas. Now, what are the investigations which can be done in patients with chronic pancreatitis? So if we look at exocrine insufficiency, then in these patients, the tests which we will carry out. So the test for malabsorption would be fecal fat test, and we know if there's increased fecal fat content, that denotes malabsorption. But the preferred test is the fecal elastase test. The preferred test is the fecal elastase 1 test. And the fecal elastase 1 test, if the value is less than 100 micrograms, then it is suggestive of malabsorption. So if the value of fecal elastase 1 is less than 100 micrograms, then it is suggestive of malabsorption. And NBT PABA test can also be done, but the preferred test, like I told you, is the fecal elastase 1 test. For diabetes, we will of course check for blood sugar and insulin values. We can check for diabetes mellitus. Now, the actual imaging investigations which can be done in patients, the imaging investigations, you should know that the investigation of choice is MRCP with secretin stimulation. That is the investigation of choice. But the gold standard investigation is ERCP. Gold standard investigation is ERCP, that is endoscopic retrograde cholangiopancreaticography. Now, at multiple places, we have discussed the difference between investigation of choice and gold standard. So, gold standard is one which will give you the diagnosis 100% times, but ERCP is only reserved in those patients where you have to carry out some intervention as well. Otherwise, MRCP with secretin stimulation is usually carried out. Endoscopic ultrasound, EUS, can also be done in patients with minimal change disease. In minimal change disease, where there are not many changes, their endoscopic ultrasound is quite sensitive. And an endoscopic ultrasound modality to diagnose these changes is the Rosimond criteria. So Rosimond criteria is endoscopic ultrasound features to diagnose chronic pancreatitis. And again, the details have not been asked in the exam. All I want you to know that in the Rosimond criteria, you have parenchymal features and you have ductal features. You have parenchymal features and there are ductal features which are there. And it is endoscopic ultrasound guided modality. One more thing which I want you to know is the chain of lakes appearance. The chain of lakes appearance can be seen in patients with MRCP, and this chain of lakes appearance develops because of stones. So if there are multiple stones in the pancreatic duct, then there'll be pancreatic secretions in between these stones. So it gives an appearance of a chain of lakes, right? Gives an appearance of a chain of lakes, and this sign you should know on MRCP. This is seen in chronic pancreatitis. This has been asked in the exam. So I also wanted to share some images with you. You know that Indonesia is an archipelago. That means there are multiple small islands scattered in a big ocean. So that also looks like a chain of lakes only, right? If you look from above. And this is one of the beautiful places where you can see sunset. And this was another beach in Indonesia, which I wanted to show to you. So this is the chain of lakes appearance, which we can see on MRCP. Also, CT scan can be done, and on CT, you will see fibrosis inside the pancreas. There'll be fibrosis which can be seen, calcification which can be seen inside the pancreas as well. And these are the features which you will see on contrast enhanced CT scan. So these were the investigations. Now moving on to the management of chronic pancreatitis. So the management of chronic pancreatitis, if the patient has exocrine insufficiency. So for the exocrine insufficiency, where the patient has malabsorption, we have to supplement exogenous pancreatic enzymes. So exogenous pancreatic enzyme supplementation is given. And this exogenous pancreatic enzyme supplementation, usually 90,000 international units of supplementation is done. And this is usually clubbed with a proton pump inhibitor so that these the lipase or which is being given can easily go into the small bowel as well. So this supplementation helps with the malabsorption, and 90,000 international unit supplementation has to be done on a daily basis. If there is endocrine insufficiency, we have to give insulin in these patients, or oral hypoglycemic agents have to be used. How do we manage patients who have pain? So those who have pain, we first give them adequate painkillers. Adequate painkillers are given, and these can be both opioids and non-opioid painkillers which can be used in these patients. So both opioid and non-opioid painkillers can be used. If painkillers are not helping, if the painkillers are not helping, then we have to think about intervention in these patients. And what are the intervention modalities which are there in patients with chronic pancreatitis? So intervention can either be in the form of drainage procedures, or it can be in the form of resective procedures, right? So we can either have drainage procedures or there can be resective procedures. And drainage procedures, it also depends on the size of the main pancreatic duct. So this depends on the size of the main pancreatic duct, the diameter of the main pancreatic duct. Now, if the diameter of the main pancreatic duct is less than 5 to 6 millimeters is the diameter, right? If the diameter is small, less than 5 to 6 millimeters, then we can just do ERCP plus sphincterotomy, right? We can do ERCP plus sphincterotomy, and we can remove the stones which are a cause of pain endoscopically as well. We can remove stones as well. So this is if the diameter is less. Now, if the diameter is more than 5 to 6 millimeters, that means we can anastomose the main pancreatic duct. And here there are two surgeries which can be done. We can either do the Duval method or we can do the Pusto's method, right? We can either do Duval or we can do Pusto. And Duval and Pusto, this is the Duval's method. And in the Duval's method, what is done? An end-to-end pancreatico-jejunal anastomosis is done, right? So the end of the pancreas is anastomosed with the end of the jejunum. End-to-end pancreatico-jejunal anastomosis is Duval's procedure. Whereas Pusto's procedure is also known as longitudinal pancreatico-jejunostomy. Longitudinal pancreatico-jejunostomy. So here what is done is that the entire length of the pancreatic duct, is anastomosed with the jejunum. That is LPJ, longitudinal pancreatico-jejunostomy, or side-to-side anastomosis, which is carried out, and that is Pusto's method. So you should be able to identify both the images. End to end is Duval and side to side is Pusto's method. So these are the two drainage procedures which can be carried out. Now sometimes what can happen that the pancreatitis can be limited. Pancreatitis can be limited to a particular segment. If the chronic pancreatitis is restricted to the head, if it is restricted to head, then we can carry out Beggar's procedure. And Beggar's procedure is duodenal preserving pancreatic head resection. This is duodenal preserving pancreatic head resection. Duodenal preserving pancreatic head resection is Beggar's procedure. Okay. Whereas if the pancreatitis is restricted to body and tail, if it is restricted to body and tail, then we will carry out distal pancreatectomy in these patients. Then we are going to carry out distal pancreatectomy in these patients. Okay. Now, one more thing, if we combine Pusto and Beggar, if we combine Pustos and Beggar, then we can get the Fraze procedure. So if you have pancreatitis restricted to the head and there are stones also which are there all along the duct, then we can do Fraze procedure, which is pancreatic head resection, duodenal preserving, along with longitudinal pancreatico-jejunostomy. So these are the various surgical options which are there in chronic pancreatitis, and I've told you that chronic pancreatitis can increase the risk of pancreatic cancer. So this brings us to the end of this module. As we've been discussing for final year students, the short note questions. In fact, acute pancreatitis is a long question where causes you are asked to enumerate, and then you are asked to talk about the management or Ranson's criteria. Then you can be asked about pseudocyst, which is a very common short note which is asked. Pseudocyst is a short note, and chronic pancreatitis also is asked as a short note in the college exam. Okay. Let's do some MCQs before we end this module. A patient with acute pancreatitis 7 days post-admission complains of fever with chills and rigors. Right, so fever with chills and rigors means there's some infection. TLC is 21,000 and CT scan reveals extraluminal gas. Remember, extraluminal gas means there's infected pancreatic necrosis. And what do we carry out here? Percutaneous drainage has to be done first. Percutaneous drainage has to be done in these patients. All of the following derangements can be expected in a patient with acute pancreatitis except. So hypoalbuminemia can be there, hyperglycemia can be there, azotemia, that means increase in kidney function, can be there. Hypercalcemia, no, there is hypocalcemia which is seen. Which of the following parameters is not included in the Ranson scoring for acute pancreatitis? Age more than 55 is there, glucose more than 200 is there, WBC more than 16,000 is there, LDH more than 250 is not there, LDH should be more than 350 international units per liter. Right. Which of the following statements is false regarding the usage of CT in acute pancreatitis? It is the investigation of choice. True. It should be done within 72 hours. False. It should be done after 72 hours because otherwise before it is going to underestimate. Balthazar's criteria is used to identify severity. This is true. And sign of sepsis is an indication for CT scan. This is true. Which of the following statements is not true? Pancreas divisum is the most common congenital pancreatic anomaly. True. Divisum is caused by failure of fusion of dorsal and ventral pancreatic ducts. True. Annular pancreas presents with bilious vomiting. False. I told you this is not there. It is non-bilious usually. Sign on annular pancreas can be double bubble sign. True. Treatment is duodeno-jejunostomy. False. It is usually duodeno-duodenostomy. And annular pancreas occurs because of failure of complete rotation of ventral pancreatic bud. This is also true. Which is of the following is not used to assess severity? So Ranson's is used, Apache 2 is used, HAPS is used. So all of them are used. And finally, regarding complications of acute pancreatitis, which of the following statements is not true? Splenic artery pseudoaneurysm is the most common vascular complication. This is true. Pseudocysts are more common in chronic pancreatitis. True. Right-sided pleural effusion. False. Left is more common than right. And splenic vein thrombosis can give rise to left-sided portal hypertension. So that brings us to the end of this module on benign pancreatic disorders. In the next module, we'll talk about the cancerous conditions or the malignant conditions of pancreas. Thank you.